Thank you, Dr. Vinay. It's indeed gratifying to see the hall almost full at 9:30 in the morning. You know the reason why we conduct this annual session, it's predominantly a teaching exercise concentrating on the practical aspects of infectious diseases. So you will not find probably much of theory in our meetings, but hopefully it will make you better clinicians practicing your medicine on a daily basis. The reason why we started this session with cough and fever is evinced by this article which came in 2014. This was an article from the Journal of Antimicrobial Chemotherapy which looked at the trends in antibiotic prescribing in primary care for clinical syndromes subject to national recommendations to reduce antibiotic resistance in UK from 1995 to 2011. And I don't know how many of you will be able to read this, but I will just read a couple of sentences. The proportion of cough cold episodes for which antibiotics were prescribed decreased from 47% in 1995 to 36% in 1999 before again increasing to 51% in 2011. And the conclusions were the implementation of national guidelines in UK primary care has had mixed success, with prescribing for coughs and colds both in total and as proportion of consultations now being greater than before the recommendations were made to reduce it. In other words, people were using antibiotics much more often in situations where it was not indicated. The same thing is happening in India also. There is a phenomenal abuse of antibiotics and resultant increase in antimicrobial resistance. So the 2012, the various societies, medical societies joined together and brought out the Chennai Declaration, which basically was an initiative to see how well we could modify antibiotic use and make it more appropriate. There have been several recommendations. Dr. Ghafoor has been playing a very active part in this, and maybe he can expand on this a little more today and tomorrow probably in this thing, on how the various measures have been suggested to reduce antibiotic or ensure that antibiotics are used more appropriately, starting with stopping the over-the-counter sale of antibiotics, no antibiotics without prescription, and several other aspects. So with this prelude, I would like to tell you probably the only message you need to take home after this maybe 2-day conference would be 4 things you can do to make a difference. No prescribing of antibiotics for simple coughs and colds, no prescribing of antibiotics for viral sore throat, limiting the prescription for uncomplicated cystitis to 3 days in an otherwise fit women, and limiting the prescribing of antibiotic agents over the telephone, which quite often all of us are guilty of, except to exceptional cases. So with this, we will start with the first case. It's a 37-year-old male who had no significant comorbidities. He was a non-smoker. He presents to you with a cough of 5 days duration with a low-grade fever. He is bringing up scanty expectoration, and he also complains of some irritation in the throat which precedes a bout of coughing. He denies any history of wheeze or dyspnea. On examination, he is afebrile. Ear, nose and throat examination is essentially normal. Chest is clear, and he only has a persistent low-grade fever for 5 days. What would you do? Any thoughts? Basically, you know that there is no pneumonia, there is no at least clinically obvious acute sinusitis, otitis media, pharyngitis or laryngitis. So this would come under the category of an acute bronchitis, which means the patient has fever, cough, clear lungs, all other examination is normal. So if you look at the algorithm for acute cough, which means it is generally less than 3 weeks, you need to differentiate the life-threatening conditions from probably conditions which can be handled in a much more sedate manner. The severe conditions would include an acute severe pneumonia, severe exacerbation of asthma or COPD, a pulmonary embolism which can also present with cough, and maybe heart failure. All these conditions can be reasonably easily diagnosed in most situations. So with history and examination, if you define that this is not a life-threatening diagnosis, it could be infectious, which could be upper or lower respiratory. It could be exacerbation of pre-existing conditions like asthma, bronchiectasis, or what is now referred to as an upper airway cough syndrome. The upper airway cough syndrome is a new name given for the old terminology of post-nasal drip. So the post-nasal drip, which is usually a complication of sinus infections or other upper respiratory inflammation, can present with only a dry, irritant cough. And of course, COPDs. To this, I would also like to add 2 conditions which are commonly more seen with chronic cough, a gastroesophageal reflux disease or eosinophilic bronchitis, or what we refer to as tropical pulmonary eosinophilia, or what we used to think of tropical pulmonary eosinophilia, which still is quite a common condition for chronic cough. Now, so after 5 days, because he's troubled, you get a chest x-ray done and the chest x-ray is normal. Again, essentially ruling out a pneumonia or a lower respiratory infection. So what would be the causes of acute cough B in a patient with normal chest radiograph? It's usually due to viral respiratory infections. It could be several of the viruses, RSV, rhinovirus, influenza, adenovirus, or metapneumovirus. It could be again an acute bronchitis, which is again bacterial, an inhaled foreign body, or inhaled toxic fumes. So you would understand that most of these conditions, if not all, do not require antibiotics. But the patient is troubled. He is now come to you on the 6th day saying, I'm still troubled. How do you manage his cough? So you need, if he has a fever, you need to ensure that you are giving symptomatic treatment. The most important aspect of any treating of any patients is please provide symptomatic relief. Irrespective of whether you treat the primary problem, he needs symptomatic relief. So you would prefer a first generation antihistaminic, diphenhydramine, which is Benadryl, or chlorpheniramine, Advil, are still believed to be the best antihistaminic agents for cough. The non-sedative, currently available and frequently used antihistaminics are generally not recommended or generally not useful in the control of cough. You can give cough suppressants in the form of dextromethorphan or codeine, and it's also been found that naproxen is a very useful adjunctive in the control of cough. You also need to reassure the patients. Again, like I said, the patients get very worried. I'm 6 days, doctor, 7 days, there is no fever and I'm still coughing. I'm feeling uncomfortable. So the advice about the natural history of the illness has to be told to the patient. In general, most cases of acute otitis media last about 4 days. Any acute sore throat or pharyngitis can last up to a week. A common cold may run the course for 7 to 10 days. Acute rhinosinusitis may last up to 2 to 3 weeks, and acute bronchitis may have a persistent cough lasting up to 3 weeks. So you need to ensure that the patient is informed about this so that he is at least reassured that the persistent cough is not significant of anything serious. What about the role of antibiotics? I'm sorry for the small print, I just cut paste a few things. As far as evidence-based recommendations for antibiotics go, I will read out the 5 points here. Amoxicillin is the preferred treatment in patients with acute bacterial sinusitis. When you suspect sinusitis, which is manifest as cough, maybe due to postnasal drip, facial pain, maybe runny nose and fever, in general, most of the cases of sinusitis are viral. So for up to 5 days, no antibiotics are advised. Only if the symptoms of sinusitis last more than 5 to 7 days or a pre-existing problem worsens after 5 to 7 days, you need to give antibiotics for sinusitis, which is usually bacterial in nature. Otherwise, majority of sinusitis is viral. Amoxicillin is the preferred treatment for patients with acute bacterial rhinosinusitis. A short course antibiotic therapy of 5 days duration is as effective as 10 days of antibiotics in uncomplicated sinusitis. So keep your antibiotics for a shorter duration. Antibiotic therapy should be considered for children from 6 months to 35 months of age who have acute otitis media. But for adults who have acute otitis media with effusion, oral antibiotics is not generally recommended. Penicillin should be used for patients with streptococcal pharyngitis. And please remember, no antibiotic should be prescribed for acute laryngitis. So when somebody comes to you with hoarseness of voice and loss of voice, which is classical of laryngitis, please avoid using antibiotics because they make no difference. What antibiotics would you choose? Simple, first, the early generation penicillins in the form of amoxicillin, or first generation cephalosporins in the form of cephalexin. Clindamycin, co-amoxiclav are good enough. Routine use of second or third generation antibiotics should be discouraged. Even though they work, you don't need to go for the big guns. The simple antibiotics are good enough. We'll move to the second case scenario. This is a 22-year-old student who's studying for MBA at Warwick University in the UK. He has lived in the UK for the last 1 year, but he's now come to India because he's not feeling well. And he had been well for up to 1 month prior to his presentation to you. He has a history of cough for 4 weeks, which is predominantly dry. He says he gets it in paroxysmal bouts, mainly at nights, which disturbs his sleep. He's also tired. He says that when he gets about a severe cough, towards the end of the bout, he has some wheeze also. There is no dyspnea, and he also complains of lack of appetite. On examination, you find that he has a low-grade temperature even though he didn't give the history. There is no pallor clubbing or lymphadenopathy. Ear, nose, throat examination is normal. Cardiovascular system is normal. Chest is clear and abdomen is showing no organomegaly. In other words, he just presents to you with cough, tiredness and loss of appetite, and on examination you find he also has a low-grade fever. How would you approach this case of what we would call a subacute cough? An acute cough is usually less than 3 weeks, a chronic cough is more than 8 weeks, a subacute would fall between these two. So you need to take a history and physical examination. It could be a post-infectious cough, which is again the common cause reason for a subacute cough. The post-infectious cough could be due to a follow-up of a lower respiratory infection. It could be sometimes due to pertussis. Now pertussis is often an underdiagnosed entity. Pertussis can cause a persisting cough lasting for several days to sometimes weeks. And of course sometimes bronchitis can also cause cough which may persist for more than 3 weeks. Any new onset or exacerbation of a pre-existing condition in the form of either sinusitis with postnasal drip, asthma, GERD or bronchitis has to be thought of, and if this is ruled out, you need to approach it like a case of a chronic cough. So with this patient who is generally unwell enough to come to India from UK for his 4-week symptoms, what would you do? You do baseline investigations, you find that his total count is 7,600, polymorph 65, lymphocytes 33, eosinophils 2. So he has no significant eosinophilia, but ESR is elevated, 78. His renal and liver functions are normal, alk phos is slightly elevated, and albumin globulin show that the globulin is increased, suggesting usually some sort of a chronic inflammatory problem. Malarial parasite blood culture is sterile, a chest x-ray is normal, and the ultrasound abdomen is normal. In other words, he has a cough, features suggest of some chronic inflammation, he is febrile, but everything is alright. So how would you approach? If it is post-infectious, again rule out a postnasal drip, any upper airway irritation, mucus accumulation, bronchial hyperresponsiveness suggest of an underlying airway obstruction, allergen, persisting infection or COPD. Again, as I said, consider the possibility of pertussis infection, which may require a course of antibiotics, usually a macrolide, and you need to ensure that in such cases where you suspect at least 5 days of respiratory isolation or infection control is necessary to prevent the spread of infection. But most importantly, management would be with some inhaled ipratropium or inhaled steroids or codeine till you work out what is the cause for the cough. Symptoms persist. He has now been in India for a week, you have done all these investigations, what would you do? Any thoughts? Nobody wants to? TB screen. Okay, what would you do for a TB screen? We have got an excellent talk coming up later on what you should and what you shouldn't do for TB. But TB screen, you would like a Manto or you would like a TB Gold, quantiferon? Sputum. He's not bringing up much sputum. I think he said very scanty expector. No, it's a dry cough. There's no expectoration at all. You're not able to get that sputum out. Saliva. Saline nebulization. Yes, that's a very good thought. Saline nebulization can be tried, but it is unsuccessful. Nobody wants to comment on a CT scan. Throat swab. No, in such a situation, usually when there is no evidence of an upper respiratory infection, there is no point in doing a... Now, the hints for this case which prompt me to consider a CT scan would be the fact that he's been unwell for more than 4 weeks. He had a clear chest, a normal chest x-ray. He has a raised globulin, a high ESR, pointing towards some chronic underlying inflammation. And the reason I'm putting this up is we are seeing more and more cases where we find that the mediastinal lymph nodes due to tuberculosis is not picked up in any other fashion. The lung fields may be clear. The CT scan of the chest was normal except for the fact that he has some mediastinal nodes. So consider this possibility as one of the reasons, especially when you find a high ESR, features of inflammation and a persisting problem in a febrile patient with cough. So they may present this as some necrosis is seen. Now it is very difficult to comment on necrosis on a CT scan. You can say that there is some area of hypodensity in the lymph node, but assuming that presence of necrosis or hypodensity is specific for TB is not correct. So when you find mediastinal lymph nodes, the 3 typical differential diagnoses would be tuberculous lymphadenopathy, sarcoidosis or lymphoma. A Manto or a TB Gold, please remember, are only tests to diagnose latent TB. 50% of the Indian population will have a positive Manto or a TB Gold. So it's as good as a flip of a coin. We will go through in subsequent lectures. Calcium serum angiotensin converting inhibitor level and slit lamp examination may help in getting a little more information but are not specific in the diagnosis, and serum LDH may be very high in cases of lymphoma, but again this is not a specific test. These are just small clues to help you differentiate in what we need to do. So in this patient, quite often if we need to confirm the diagnosis, we may need to do a bronchoscopic ultrasound guided biopsy or an endoscopic ultrasound guided biopsy to get at the lymph node biopsy or a needle aspiration to prove the point. And again, gene expert, which will be discussed subsequently, is a very useful adjunct in diagnosing TB. The next case is a 34-year-old male, an IT professional who comes to you with a complaint or complaints of cough for 3 months. He's feeling unwell, he's complaining of a feverish feeling, very tired, loss of appetite, but he says, I'm gaining weight. He's married for 5 years, no children, smoker about 10 a day and drinks alcohol 3 to 4 times a week. On examination, he keeps on coughing all the time. Okay? What are the causes of a chronic cough which lasts more than 8 weeks? Usually it is reflux disease or airway obstruction or rhinitis. Now you examine the patient, there is nothing to suggest all this. Sometimes if you are not clear, empiric treatment for upper airway cough syndrome in the form of either a short course of antibiotics or treating him for GERD is perfectly acceptable. You try this, there is no improvement. You can give antihistaminics, oral nasal decongestants, antibiotics, steroid inhaler, proton pump inhibitors with a prokinetic agent, and also make sure that you take a history of ACE inhibitors, because that is again one of the causes which may be associated with a chronic cough. So you've done all this, no change. It's a very complicated algorithm. Again, I don't know how many of you can see it from the back, but I'll just highlight a few things. You need to investigate, especially ask for history of smoking, ACE inhibitors, discontinue if it is found. Upper airway cough syndrome can be empirically treated with a short course of antibiotics. Asthma, again, a simple PFT, a peak expiratory flow rate, can give you some hints. A eosinophilia, you do a peripheral smear and a total differential count for eosinophilia will help, and also empiric treatment for GERD will be useful. Just look at the right side of the table. It says that if it is wheezing episode, it is asthma. If the person complains of clearing his throat, very often think of a postnasal drip or an allergic sinusitis, rhinitis. If it's a wet, productive cough, think of infective conditions or bronchiectasis. If there is choking after feeds, think of recurrent aspiration, especially in the elderly. A brassy or a barking cough is tracheobronchiomalacia or airway compression. A bizarre cough which disappears when asleep. So it's a very useful question to ask a patient who has a chronic cough, does it disturb your sleep? Because if it is a significant cough, usually the sleep is disturbed. In fact, several coughs exacerbate during the night time. But if the patient says, no, I go to sleep, I get up in the morning, and you ask the partner says he doesn't cough at night, then you have to be a little careful, because la belle indifference, which basically refers to a psychogenic cough. And a dry cough with breathlessness could be interstitial lung disease. But all this will be picked up chest X-ray or CT scan. Now this gentleman had a complete workup done, everything was perfectly normal. And on questioning, we found out that he had a good sleep and he was under a lot of stress. Please remember, pain and cough are two symptoms which you cannot argue with. If the patient says he has pain, he has pain. There is nothing on earth you can do to confirm or rule out the pain. You can try to come up with reasons for it. Similarly, if he has a cough, and cough is very easily produced. I recently had another young student, 9th standard student, who kept on coughing, He wouldn't sit in my outpatients. He kept on coughing so badly that, and turned red on the face. But then you ask, he used to sleep comfortably, and then on questioning, he had a lot of stress in school. And once that was addressed, the coughs completely disappeared. So this IT professional also was a similar case, So please think of, when CT scan is normal, everything else is normal, then probably simple way is to go behind what could have caused the problem. So I'm going to leave you with this. I think probably the most important lesson you need to keep in mind is rule out TB, cancer, and probably HIV also, as we will see later in subsequent session. And once you do that, I think it is much simpler only to treat the patient symptomatically. Now this year we have tried to restrict the length of the talk so that there will be some time for discussion, because one of the frequent criticisms during our earlier conferences was that there are a lot of topics but no time for discussion or interaction. So I'm giving you a cool another 3 to 4 minutes for asking questions if you have any. When I say that, nobody wants to ask any questions. Yes. Now, what you say is right, but which means you need to give symptomatic relief, which would be, like I said, using a first generation antihistaminic, using a cough suppressant, and most importantly, ruling out serious underlying problem. I told you the last slide, rule out cancer, rule out. So probably if it is necessary, if the person is so troubled and it's so persistent, a CT scan probably would be the last option after doing pulmonary function tests and other investigations to make sure that nothing serious is being missed. Right. If there are no questions, I think there's a lot more to go. I'm going to ask Vinay, who's going to speak next.
Thank you, sir, for a very informative presentation. I request all the delegates to be more active in terms of discussion. You can come up with more doubts. We have ample time for discussion. Plenty of talks ahead. Our next speaker today is Dr. Vidya Devarajan. She is an associate consultant in infectious diseases, HIV and tropical and travel medicine at Apollo Specialty Hospitals and also Apollo Main Hospital. She is an alumnus of Ambedkar Medical College from Bangalore, and she's done a TNB internal medicine from Apollo. She's a trained F&B fellow from Apollo Infectious Disease Institute. She has also cleared a specialty certificate in ID training from Royal College, UK. She has multiple publications and posters to credit. She will talk you through a very important presentation and a problem in OP practice, which would be fever with lymphadenopathy or lymphadenopathy per se. I invite Dr. Vidya to take over the stage, please.
Thank you, Dr. Vinay. Good morning, all of you. Actually, when I got the topic, this is how I was, and I'm sure in the OP, a lot of us sit this way when we actually get a patient with lymphadenopathy and really don't know what to do. But I'm sure we'll all grow bolder and more beautiful with time, and probably at the end of the 2 days, I hope there is some learning session too. The objectives of today's talk would be, I'd just brief you on knowledge of nodal distribution and anatomical drainage, provide an approach to a patient with peripheral lymphadenopathy with case scenarios, so that you should be able to be differentiating between benign and serious conditions, and provide a substantial differential diagnosis, and what would be the indications for nodal biopsy. Just a brief note on drainage of lymph nodes. Okay, every time you examine a patient with lymphadenopathy, make sure you're also looking at the draining area. Important because you know your right-sided supraclavicular nodes drain your mediastinum and the lung, and the left one is the abdomen. The rest of them are pretty simple. I just thought I would point on to that. The lymph node enlargement, it could be because of a various reason. It could be just benign lymphocytes and macrophages in response to antigens, or it could be inflammatory reaction or infiltration due to inflammatory cells, or it could be malignant cells proliferating, or it could be a metastatic infiltration. And most of the time, presentation of lymphadenopathy, that is the 3/4 of the cases who present to you with lymphadenopathy, are localized, and about a quarter are generalized. Basically, there are 600 lymph nodes in the body, and there are primary hundreds of illnesses. So probably the lymph node could be a manifestation of a significant underlying disease, and that's for you to decide. So most cases, actually, the literature from India regarding the epidemiology of lymphadenopathy is sparse. Although there are quite a few studies depending upon the centers, whether it's a primary center presentation or a referral center presentation, which I'll come through a little later. But remember, most cases are benign based on literature and self-limited. The challenge is to decide if it's representative of a serious illness like I told you. So we'll go on to the case. We have a 25-year-old male, a school teacher who presents to you with right-sided cervical adenopathy. The duration of this is about a week. He has no other localization. His past medical history is significant for hypertension and dyslipidemia, for which he is on simvastatin. Physical examination, you have a 2 centimeter anterior cervical node which is firm, which is non-tender and mobile. And like I told you, the drainage areas are unremarkable. He has no skin lesions, and always look at the other areas. Whenever you have an adenopathy in one site, make sure you examine all other areas to rule out generalized lymphadenopathy. So he has no other palpable lymph nodes. So how do you think you'll proceed with this patient? Location and duration are typical for a viral etiology. So have your patient follow up for annual physical visit next year. Proceed, go on and do an FNA. Ask for an X-ray and a CBC. Have a patient follow up in 3 to 4 weeks time. So basically somebody who's young, 30 plus, school teacher with absolutely no symptoms, presents to you with a cervical node which is about 2 centimeter in diameter with no constitutional symptoms. So how do you think we should proceed? Okay, so this is a study which was published a little ago in 1980 though on 925 biopsies, and it said age less than 30, 79% benign. I mean the biopsy would be benign, 15% lymphomatous and 6% carcinomas. But mind you, age more than 50, malignancy or carcinomas usually tend to increase. Okay, so age definitely matters when you actually look at your patient along with the other symptoms. So how do we actually proceed with this patient? This is a patient with no constitutional symptoms, young and fine, perfectly fine. So what we actually do is follow up this patient in 3 to 4 weeks. So that would be an approach to a patient who presents to you this way. So in general practice, less than 1% of patients will have lymphadenopathy who will actually present with a malignancy. But then this is, again I told you, it's a primary, it's a general practice. In a referral based center, your percentage goes up to about 17%, and sometimes it soars to as high as 40 to 60% in highly suspicious patients. We'll move on to case 2, which is a 23-year-old girl from Puducherry. She has history of fever for the last 15 days, neck swelling for 1 week, no constitutional symptoms, past medical history, family history and personal history non-contributory. On examination, she has bilateral cervical lymph nodes with a faint erythematous rash over her body, and there are no other lymph nodes palpable and no organomegaly. And this is what her labs are: hemoglobin of 8.2 with a borderline platelet, with a borderline white count as well, with some transaminitis, X-ray is normal, and ultrasound no organomegaly, and no adenopathy also. So what do you do next? So this is a girl who presents to you with 15-day, young girl, 15-day fever, cervical node and a faint rash with some anemia, transaminitis and anemia and transaminitis, or probably like cytopenias and transaminitis. No constitutional symptoms. So do you get the FNA or biopsy done? Do you ask for a PET scan? Do you review your history, refer the patient to us, or start on antibiotics? Do you want any other history, doctor? Okay. So fever with regional lymphadenopathy could be suppurative. Look at the draining areas like I told you. It could be because of bacteria like staph, strep, anaerobes, or always keep non-suppurative causes of lymphadenopathy in mind, non-suppurative as well as non-infectious causes of lymphadenopathy in mind, which could be TB, toxo, cat scratch that stops at your infectious, and your non-infectious would be Kawasaki's, which could be Kikuchi's. She's a female who's a young female presenting to you with all these symptoms. You have to keep Kikuchi's in mind. Malignancy and metastasis is definitely down on the list. So this is what her FNA showed, histiocytic necrotizing picture. So what do you think the diagnosis in this patient would be? Excellent. So necrosis does not equal TB. Granulomas and caseation necrosis can occur in tuberculosis, non-tubercular mycobacterial infections. You could get them also in cat scratch disease, tularemia. Necrotizing non-granulomatous inflammation is usually seen in Kikuchi's, SLE and Kawasaki's disease. So Kikuchi's is basically an idiopathic self-limiting disease which presents with cervical adenopathy. It could present with or without systemic symptoms. Histologically, there are reports where it has been diagnosed as lymphomas or SLE as well. And there is some data, but not really confirmatory data, that some of them could progress towards SLE. So no specific cure. Probably if they have an extra nodal site, extra cervical site, say like a mediastinal adenopathy or a life-threatening situations, then you could use steroids. Otherwise, this is self-limited and NSAIDs will suffice. We'll go on to case 3. We have an 18-year-old male with history of fever of 15 days duration, no weight loss, no systemic localization, no joint pain. He has a cat which is delivered 2 kittens, and he also has a seizure disorder for which he's been on phenytoin for the last 5 years. On examination, he has generalized adenopathy with hepatosplenomegaly, with a mild thrombocytopenia, lymphocytosis, atypical lymphocyte predominance with transaminitis. So would you agree with these differentials, or do you think we should add more to the list? And what do you think the most probable cause of? Okay, should I stop here then? Okay. Algorithm to evaluate lymphadenopathy: pay attention to history and physical exam and get some confirmatory testing as well. Look at the environmental exposure. Cat exposure, cat scratch disease and toxo are common. Undercooked meat, eating of undercooked meat, again think of toxo. Tick bite, limes, tularemias are a few diseases. Recent blood transfusion, you have to keep CMV in mind, and also keep seroconversion. Okay, I missed out on that. Okay, acute seroconversion, HIV seroconversion in mind. And then your HIV, hepatitis B, hepatitis C also could present this way. Going on to occupational or epidemiological clues. Say they are hunters and trappers, which I don't think we would come across. Tularemia, they could have tularemia. Or fishermen, slaughterhouse workers, erysipeloid. Travel related, okay, I have elaborated a little more, but basically what I'd like to say is travel history is important. For us, probably we should ask for travel to shrubby areas or like dry areas where scrub typhus is common and which could present with lymphadenopathy. And travel history, like travel to the southeastern United States where histo is common. So basically also concentrate on travel history. You can always Google then and find out what causes lymphadenopathy in that place. So remember, medications can cause lymphadenopathy. Our patient is on phenytoin. So phenytoin, carbamazepine and a wide variety of medications can cause lymphadenopathy, which could be associated with either a serum sickness like illness, or it could present with exfoliative dermatitis like illness along with your lymphadenopathy. So this patient has fever, lymphadenopathy, you've cleared off your travel history. Your drug history is significant though, but this doesn't really look like eptoin induced. You have lymphocytosis with atypical lymphocytes and generalized. I think this patient more of cervical lymphadenopathy than generalized, and you had its EBV, VCA, IgM, which was actually positive. So this case was a case of mononucleosis syndrome. So mononucleosis syndrome presents with fever, sore throat, malaise, pharyngeal inflammations. You could have adenopathy, cervical adenopathy, splenomegaly and hepatitis. Your differential diagnosis for mononucleosis syndrome is not just EBV. You could have CMV, toxo and acute seroconversion. You have to suspect mononucleosis if lymphocytosis of more than 50% with 10% atypical lymphocytes, and ask for your serologies. Basically an immunocompetent, it's all right except for the HIV seroconversion, which you need to concentrate on because the rest of them are self-limiting. Pregnancy is where you will have to rule out CMV and toxo. We'll move on to the last case. We have a 10-year-old male with swelling in the neck for the last 5 months, fever for a month with constitutional symptoms, weight loss, etc. Physical examination, he has multiple neck nodes, vertical, horizontal, non-tender, mobile nodes, and other system examinations unremarkable. His routine X-ray, this is what you see. Does anybody want to comment on the X-ray? Okay, it looks like he has a mediastinal widening. So this is a mediastinal mass. His hemoglobin is low. So our differentials in this patient could be malignancy, TB, sarcoid. Basically, I wanted to tell you that concentrate on children who present with mediastinal mass. A lot of times it could be malignancy. So that's important that, that I convey that to you at this point. This case, no specific or no pressure symptoms of the mass surrounding structures. This chronic onset fever with weight loss, with a mass detected on the X-ray, and 50% mediastinal masses are, like I told you, are malignant. So what next would you do for this patient? You have palpable lymph nodes all over as well. Okay. Okay. This is what the biopsy showed. Necrotizing granulomatous inflammation. So would you stop at this? What are the samples that you would ask for on the biopsy specimen? Okay. You will ask for a HPE. You will also ask for an AFP smear and culture. I do agree more than 50% of the mediastinal masses in children could be malignancy, but cultures are crucial because this patient had a positive AFB culture as well. Okay, and just a word on gene expert on the lymph node specimen. The sensitivity and specificity of the expert assay on the lymph node is about 91.5 and a specificity of 70.4%. So cultures are crucial, and this also gives you a emphasizes on importance of tissue diagnosis. So what's appropriate? How many more minutes do I have? 2 more minutes? 5 minutes? Yeah. Okay. Fine needle aspiration is convenient, less invasive, quicker turnaround time, and most patients with a benign diagnosis on FNA do not need to undergo a surgical biopsy. Examples of appropriate patients to refer for a biopsy would be a solitary hard cervical nodule, a supraclavicular lymphadenopathy, a generalized firm rubbery lymphadenopathy with systemic symptoms, and these are a few of the rules for excisional biopsy. Use the largest and most abnormal palpable node, avoid previously irradiated areas, and supraclavicular, the yield is more, followed by cervical axillary. Remember, inguinal, the yield is less, so avoid inguinal node biopsies and always ask for cultures. So what are a few yeses and no-nos in lymphadenopathy? Lymphoma suspects, excisional lymph node biopsies are preferred. You'd also need IHCs later on them, and if suspicion for an underlying malignancy is high, an unrevealing lymph node biopsy should be considered non-diagnostic, not just negative for malignancy. So you chase the lymph node again. So that's an important point. And when you get a report saying it's an atypical lymphoid hyperplasia, rather than, you should not consider this non-diagnostic rather than negative for a malignancy, and you should really follow up the patient. Patient should be carefully followed and additional lymph node biopsies are strongly considered. Very important no-nos of a lymph node biopsy. Do not use glucocorticoids unless life-threatening situations or systemic illness dictates it. For example, SLE flare or say cord compression or superior mediastinal syndrome. In such cases you could use, and this is because of the lympholytic effect that the steroids have on the lymph nodes, you could delay the diagnosis of lymphoma. So conclusions, I would conclude by saying generalized lymphadenopathy should always prompt further clinical evaluation. Repeated examination does help. Most important is detailed and elaborate history. Planning and biopsy and FNAC in time is important. Cultures are crucial. Thank you. Definitely. So always ask for history of recent immunization. Okay, like even trauma or an injection at the site would cause a localized adenopathy, or vaccination, recent immunization per se could cause adenopathy. Thank you.
Thank you, Dr. Vidya.